All right, so this is the AMSSM National Fellows Online Lecture Series, put on by um, the Fellows Online Education Subcommittee that is part of the Education and Fellowship committees with AMSSM. We're honored today to have Dr. Katharine Hollnagel here to speak to us. She's a orthopedic surgeon, but she did two fellowships beyond her orthopedic surgery residency. So she did um, pediatric fellowship, and then she also did um, a hip preservation fellowship as well. And currently, she's at University Hospital's Rainbow Babies and Children's, where she does general pediatric orthopedics, as well as young adult and pediatric hip preservation surgery. So we're super lucky to have her here tonight. I know she's going to give a great talk. Just to go over a couple goals of this evening. So this is not to replace any of your education that you're getting at your home fellowship program. This is more of an adjunct to that with different lectures throughout the year. And this is to really help with your board exam preparation. Um, you're welcome to give us feedback about talks or topics, speakers that you think would be really beneficial to be included in this online lecture series. So you can go to the AMSSM website and pass on this information. The other thing you can do, you can scan this QR code here, and that will be a direct link so that you can give suggestions for these online lectures. And then the other thing that you can give us suggestions for, if you have some really interesting ultrasound cases, you can submit those. You can use the QR code here, or you can email these emails here at the top. And then tune in next week. So, same time, Wednesday evening. The topic is going to be the overhead throwing athlete, looking at the biomechanics and the kinetic chain. The speaker is Dr. Kayla Holtz-Nussbaum, and the moderator is Dr. Matt Wise. So just make sure you're muted. If you have any questions at any point, you can put it in the chat. Otherwise, there will be time for Q&A at the end. And then we do ask that you complete the evaluation. That helps us pick topics and speakers in the future as well. So to get back to it, let me stop sharing my screen and let Dr. Hollnagel get started. And thank you so much for joining us.
All right. Well, thank you so much for the opportunity to talk this evening. My name is Kate Hollnagel, and I'm in Cleveland, Ohio, at Rainbow Babies and Children's Hospital. And tonight I'll be talking about evaluation of the pediatric hip. I don't have anything to disclose for this talk. And so obviously this is a really big topic. There's a lot to talk about when it comes to the pediatric hip. So really my goals tonight are just to give a brief overview of normal hip development, to talk about how I approach evaluating the pediatric hip, and then to also review some common hip conditions that we see in the pediatric population. All right, so just to start with normal hip development. So at birth, the acetabulum is composed completely of cartilage, surrounded by a rim of fibrocartilage or the labrum. The triradiate cartilage is at the base of the acetabulum. The femoral head is composed completely of cartilage, and femoral aneversion is around 45 degrees. Between age 0 to 8, acetabular size and depth increases, femoral head size increases, and femoral version decreases. By age 8, the shape of the acetabulum is essentially determined. The posterior wall begins to ossify, and we start to see secondary ossification centers appear around the acetabulum. And then between age 12 to 14 years, the secondary ossification centers fuse, the triradiate cartilage closes, and femoral aneversion is around 10 to 15 degrees. So what this means is that, as you are evaluating the pediatric patient in your clinic and looking at X-rays, that these X-rays really do change throughout their development. So it's really important to become comfortable looking at X-rays and kind of knowing what normal is at each age when you're evaluating these patients. And so when it comes to the pediatric hip evaluation, this can be challenging for a number of reasons. Hip development occurs through adolescence. And so, kind of like I alluded to, you really need to know what normal is at every age to really know what abnormal is. Getting a history is not always easy. Kids are not always great at localizing pain, and so sometimes it can be a little bit challenging trying to figure out what is going on, especially when it comes to the hip. Physical exam findings are often nonspecific. We'll talk a little bit about the physical exam of the hip, but when the hip is irritable, a lot of these things are going to be positive. So even though your physical exam can help you localize pain to the hip, in terms of some of these physical exam findings really helping you come to one specific diagnosis, that can actually be really challenging, especially when the hip is hurting. And then when we're dealing with kids, we're also dealing with unique injury patterns and hip pathologies compared to adults. And so it's really important to kind of know what unique pathologies you might see at given ages. And many problems outside of the hip may present with hip pain. And so it's really easy when we're in an orthopedic clinic and someone comes in with hip pain to just focus on the hip joint or the muscles around the hip. But it's also important to remember that abdominal pathology can cause hip pain, that other intrapelvic pathology can cause hip pain, that neurological problems can cause hip pain. There are a lot of things kind of outside of the musculoskeletal system that we need to remember may present with hip pain so that we don't miss something important. And then it's also important to remember that, certain hip pathologies don't always present with classic hip pain. And so, one of the classic examples of this is slipped capital femoral epiphysis or SCFE, where sometimes these patients will come in complaining of knee pain and will have therapy for their knee, will have surgery for their knee, and really that knee pain is referred pain for their hip. So it's also important, when you're taking care of pediatric patients, to not forget the hip, even if they're coming in for something else. And so when it comes to the differential diagnosis for hip pain in the pediatric patient, this list is very, very broad, and this is by no means exhaustive. And so it's really important, again, when we're taking care of patients who are coming in with hip pain, that we remember that it can be a number of things, and as we're evaluating them, to not forget that some of these other things can also present with hip pain. All right, and so, with that being said, at the end of the day, when we're evaluating a patient, we really have a limited amount of time to see them and try to figure out what is going on. And so it's also really important to try to orient yourself when you're about to go see a patient and start to narrow down that differential so that you can really perform a focused history and physical exam. So when I'm about to go in to see a patient, usually what I start with, outside of just looking at their chart and looking at the EMR and maybe looking at their imaging ahead of time, is I really start with what is their chief complaint. So what is bringing them in? And then looking at their age, because that really can help you narrow things down quite a bit, especially in terms of what's common before you go in and see a patient, so that you can really focus, your history and your physical exam. So when it comes to chief complaint, obviously pain is going to be, something that brings patients into your clinic. And so hip pain is kind of the obvious thing that may bring someone in with a hip problem. But it's also important to remember that hip pathology can cause referred pain to the knee, to the thigh, to the buttock, to the low back. And so whenever I see someone coming in for pain in any of these areas, I'm always thinking about the hip being one potential source of their problem. Limp is another big thing that brings patients in. And again, kids, especially really young kids, may come in with a limp and they might not be able to localize, where that's coming from. And so whenever someone's coming in with a limp, I'm looking at the hip in addition to looking at the knee, looking at the ankle, looking at the foot. And then leg length discrepancy is another thing that might bring someone in that may be indicative of a hip problem. And so when we think of developmental dysplasia of the hip or DDH, if a child has a dislocated hip, this is something that early on is not going to cause them pain, but it may cause them to have a leg length difference. And so whenever someone's coming in to be evaluated for a leg length difference, especially a younger patient, I'm always, again, thinking about the hip being a potential cause of that. And so just to kind of focus this sort of on the more common things that will bring a patient in, really looking at hip pain. So when we're thinking about hip pain in a child, so really someone under the age of 10, the things that I'm already starting to think about are going to be transient synovitis, septic arthritis or osteomyelitis, Perthes disease, juvenile idiopathic arthritis or JIA, or a traumatic hip subluxation or dislocation. And in young kids, this is something that can actually happen from fairly low energy mechanisms. And so it can be something that you see in your clinic and not necessarily in the emergency department. When it's an adolescent patient, things that I'm already starting to think about are going to be things like apophysitis or tendonitis, a snapping hip, a hip dysplasia, femoral acetabular impingement or FAI, pelvic avulsion fractures, slipped capital femoral epiphysis or SCFE. And then again, traumatic hip subluxation and dislocations can be something that we see in this population as well, especially with our contact athletes. They can have these subluxation episodes that bring them into your clinic. And so just beginning with the history, again, these are questions that we ask kind of regardless of what brings someone in, but are super important when we're evaluating the hip. So timing, location, associated symptoms, aggravating factors, alleviating factors, and treatment to date. And all of these things can kind of help focus you in on a potential diagnosis. And so when it comes to timing, is this something that is acute onset, insidious in onset? Was there an associated trauma? And if there was a trauma, did they have pain immediately after the trauma, or was there more of a delayed onset in their pain? And then also when it comes to the hip, especially when we're thinking about things like transient synovitis, any recent illnesses or other precipitating events that may have led to their symptoms. When it comes to location of the pain, especially trying to ask this of a child, I really like the point with one finger. This often can really help them sort of focus in on the pain that they're experiencing. And so usually that's what I start with. But typically when we're thinking about the hip, a lot of times it'll be more anterior hip or groin pain. And patients who have kind of true intra-articular hip pathology will often present with what we call a C sign, where you'll ask them to point with one finger and they kind of make a C with their hand, sort of over the lateral part of the hip and the front of the hip and say, my pain is here. And so that can really cue you into something that's maybe going on within the hip joint. But hip pathology can also lead to lateral hip pain and buttock pain as well. When it comes to associated symptoms, things that I will ask specifically about are mechanical symptoms, things like snapping, popping, locking of the hip. If they have a limp, sometimes patients may not have a limp when they come to clinic. It's something that they may notice more towards the end of the day or after specific activities. And so trying to really elicit that. If they have any associated back pain, weakness, paresthesias, any fevers or chills, if they've had a rash either currently or recently. Again, it's really important to ask about GI and GU symptoms to make sure that we're not missing something outside of the hip. And then asking about, other constitutional symptoms like weight loss, weight gain. When we think about leukemia, lymphoma in kids, oftentimes it's musculoskeletal pain that is their presenting symptom. And so it's important to make sure that we're not forgetting things like that. When it comes to aggravating factors, especially for hip pathology, I'll ask specifically about prolonged standing or upright activity, prolonged sitting, if they have any pain with stairs, either going upstairs or going downstairs, any sort of pivoting or twisting activities, and then also asking them if their symptoms are reproducible, especially with things like snapping hip. A lot of times the patient can kind of reproduce that for you in clinic, and that can really help you sort of solidify that diagnosis. And then treatment to date. I think that this can be really helpful sometimes for helping narrow down that differential. But just when it comes to treating a patient, it's really important to know what they have tried so far. Have they had a period of rest? Have they tried crutches? I'll also ask if they come in on crutches, how long they've been on crutches. Something that I see not uncommonly is kids who are put on crutches and then are on crutches for an extended period of time and then come in with hip pain because they've been non-weight bearing with crutches for weeks to months. And that actually puts a lot of stress on the hip. And so sometimes our treatment can be a cause of what someone's coming in for. I'm asking about medications, physical therapy, and what they've done in physical therapy. I'll ask specifically about injections, especially if they've had anything with lidocaine in it, mainly because that really gives you some really important diagnostic information. So if someone had an MR arthrogram where, they had a lidocaine that was injected into their joint and they had really good relief of their pain for, the first few hours after that injection, then that's really important diagnostic information that lets me know, hey, the pain that they're coming to see me for is coming from within the hip joint, and so I'm really going to focus on that. Versus if they say, I had an injection, I really didn't notice anything, in those first few hours, even though my hip was really symptomatic. And that tells me, hey, I should probably focus outside of the hip joint first, and then we can go back and revisit something going on within the hip joint if they're just not getting better. And then also asking about surgery, so any recent surgeries or surgeries that maybe they had when they were a baby or a young child. And then also surgeries outside of the hip. Again, a lot of things can present with hip pain. And so if they had an abdominal surgery, a spinal surgery, things along those lines, I want to know about that because that might also be responsible for why they're coming in. And then just getting a general history. So birth history, I'll ask specifically about whether or not the child was breech at all during the third trimester, because that really is our strongest risk factor for hip dysplasia. I'll ask about a developmental history. So, were they meeting their milestones, or are they meeting their developmental milestones? Because that can sometimes play into why they're there. I'm asking a past medical history, just because there are a lot of medical conditions that may be associated with hip pathology. Again, past surgical history, and then a family history, whether or not they have a history of hip dysplasia or need for early hip replacement surgery. A lot of families don't know why, grandma or grandpa had a hip replacement, but if they had a hip replacement when they were in their 30s or 40s, then that can definitely cue into something that's potentially developmental. Also, a family history of any neuromuscular or genetic conditions can also be helpful. And then in my athletes who come in with hip pain, I ask specifically about the sport they play, or if they play multiple sports, what position they play. Certain positions like hockey goalies very commonly have hip pathology. I ask about any sort of strength and conditioning work that they're doing outside of their sport, because sometimes that can be contributing to their symptoms. And then asking about nutrition, and especially with our adolescent female athletes, asking about a menstrual history, just because we can see stress fractures in this patient population, and that's definitely something that we want to catch early. And so when it comes to exam, I usually start with inspection. So I start with kind of, their sort of seated examination. How are they sitting when I walk into the room? That can often be really telling in terms of what may be going on. If they're able to stand, then I try to get them to stand and I do a standing evaluation. And then if they're able to walk, then I try to do a good gait analysis. And then palpation, range of motion, provocative testing. I always do a quick neurological exam. And then especially my adolescent patients and my female adolescent patients, I usually try to document a Beighton score, since hypermobility can often be associated with underlying hip issues. And so, again, I think it's really valuable as soon as you walk into the room and you're seeing your patient sitting there, to really sort of pause and take note of how they're sitting. So if you look at the patient on the left, she's sitting kind of in the classic W position. So that's already telling me, okay, this is a patient who has increased femoral aneurysm. When I see the girl on the right, clearly we're in like an emergency department setting, so that can kind of give things away. But tending to sit with the hips slightly flexed, slightly abducted, and externally rotated, that position really relieves a lot of pressure on the joint capsule if there is swelling within the joint. So thinking of things like a transient synovitis, a septic arthritis, a Perthes disease, these types of conditions where there's swelling within the joint. When I see someone sitting in that position, I know that there is, that they probably have an irritable hip joint. And then on standing, things that I look for, so pelvic obliquity, this can give you a sense of if there is a leg length discrepancy, or sometimes if the hip is really irritable, they may stand with the hips and the knees slightly flexed, and that can give the appearance of a leg length discrepancy, or cause pelvic obliquity. Also, if there is any sort of abductor weakness, that will cause the opposite hip to drop, and will also give the appearance of pelvic obliquity. I look at their lower extremity alignment. So do they have genu valgum, genu varum? I look at their foot and ankle alignment. I always do an Adams forward bend test to make sure that they don't have any underlying scoliosis. And then with the patient standing, this is typically when I palpate their spine. I palpate the SI joints, the piriformis, and the sciatic notch. And then I'll do a Trendelenburg test, where basically I'll put my hands on the greater trochanters, have them stand on the affected leg, and then I look for that contralateral hip to drop. And that tells me that they have abductor weakness, which we can see with hip pathology, with underlying neurologic conditions. There are a lot of things that can cause that can also cause hip pain. And then next I'll look at their gait. And so I'll stand behind them and have them walk back and forth. Usually I like to do this out in the hall so that I can really watch them walk. I think if you have the opportunity to watch your patient walk as they're coming in, that's also really valuable, since people tend to change how they walk when they know that someone's watching. Especially kids, when they know that someone's watching, they will really try to walk as normally as possible, or as silly as possible, and you don't always get a good sense of how they're walking if a gait abnormality is what brought them in. But when I'm looking at their gait, I'm looking at their foot progression angle. So do they in toe? Do they out toe? If they walk with more of a neutral foot progression angle, I look at what their kneecaps are doing to see if maybe they do have some underlying increased femoral aneurysm. I look to see if they're limping. Do they have more of an antalgic gait, or more of a Trendelenburg gait, or a waddling gait? Do they use an assistive device? And if so, how do they use it? And then sometimes when, patients come in, their parents will say, it's the beginning of the day. This isn't really how they walk. And so I'll often ask if they have videos of the patient walking, just to kind of see what they're concerned about and what they're noticing, especially if the limp is more episodic. And then next with palpation, palpate a number of bony and muscular landmarks kind of around the pelvis. So the iliac crest, the ASIS, the AIIS, and the direct head of the rectus. I'll palpate the psoas tendon at the brim. Pubic symphysis, adductors, the greater trochanter, and the ischium. And then looking at range of motion, typically I'll assess for hip flexion, hip internal rotation and external rotation, inflection, hip abduction, hip extension. And then I'll also look at prone hip internal and external rotation, which can be more helpful at seeing if there's an underlying version abnormality, especially with things like Perthes disease. Actually looking kind of at their prone internal rotation can be a little bit more telling than sometimes what you can see when you're looking at internal rotation and flexion. And really what I'm looking for, again, if you do any sort of reading on this and you look at what normal values are, what's reported is kind of all over the place. And so what I really care about is, I do look at what their total arc of motion is, especially if it's really, really restricted. Do they have pain with motion? Is it throughout the arc of motion or more at the extremes of motion? Is there any asymmetry? Asymmetry is almost never normal. And so if I notice asymmetry from one side to the other, that's something that I really pay attention to. And then looking at underlying version abnormalities, especially if I think it's contributing to what brought them in, or if it's contributing to either intra-articular or extra-articular hip impingement, that's always something that I make note of. Then when it comes to provocative testing, there's a lot of tests that have been described for hip pathology. And if someone comes in with a really irritable hip, I'll tell you that almost everything is going to be positive and everything is going to hurt. In terms of the provocative tests that I do with most patients when they come in, these are the ones that I typically start with because they can at least help me kind of localize, is this coming from the hip or maybe somewhere else? As we'll usually start with a log roll, just gently rolling the hip in and out. That kind of gives me a sense of if something's coming from the hip joint and also just how irritable the hip joint is. If the hip is super, super irritable, then I try to not torture the patient with taking them through all of the provocative tests that we could possibly do for the hip. But it's a really good test for is this coming from the hip joint or not? And then I'll do a fader or flexion, adduction, and internal rotation. Faber, which is flexion, abduction, and external rotation. A lot of us kind of know this is a test for SI joint pathology. And if they have pain kind of localized to the SI joint, it's a great test for that. But it's also a good test for hip joint pathology if they're complaining of more pain kind of within the hip joint. It can also be a really good test for hip impingement. And then I'll do a Stinchfield, which is basically a resisted straight leg raise, and that's also a really good test for hip pathology. And then I think it's really important to do a neurologic exam. So this is kind of like the 60-second or the 90-second neurologic exam. I'll do some basic strength testing, sensation. I'll ask them to do a single leg hop, walk on their heels, walk on their toes, check reflexes. It's really important to look at the feet. Patients with intraspinal pathology or underlying neuromuscular disorders can often have a foot pathology is kind of an initial symptom. And so, the foot here on the right is a cavus foot, and someone with shark with CMT, and those patients can have pretty significant hip dysplasia. And so doing a quick foot exam can often be really revealing. And then also looking at popliteal angles. And then again, in my adolescent female patients, I'll check a Beighton score just to get a sense of if they have any sort of underlying hypermobility or not. And so typically when we're evaluating someone who comes in with a concern for an underlying hip problem, usually we're also getting imaging as well. And typically where I start is with x-rays. So in children, essentially patients under the age of 10, if they can stand, I'll try to get a standing AP pelvis and then a frog lateral pelvis. In my adolescent and young adult patients, my typical series is to get a standing AP pelvis, a bilateral hip false profile view, and then a bilateral hip 45-degree or modified done view. And then if they come in either to clinic or if they come into the ER as a trauma and they're unable to bear weight, that may indicate an unstable SCFE. It may indicate a femoral neck fracture. We really try to minimize how much manipulation we do of the hip in that setting. And so typically I'm getting a supine AP pelvis, and then I try to get a cross table lateral of both hips so that we're not abducting the hip and getting it in that frog position. And I think it's really important to make sure that we're always getting x-rays that show both hips, especially when we're, looking at the developing hip at the pediatric hip. It can sometimes be challenging to determine what is normal versus what is abnormal. And so having that other side to compare it to is really, really helpful. Also, a lot of the things that we may see in this population may happen on both sides. And so it also helps us, not miss something that may be going on the other side that just isn't symptomatic yet. And so when it comes to common hip conditions, starting first kind of with, hip pain in a child or a patient under the age of 10. Again, the things that are sort of the most common in this population are going to be things like transient synovitis, septic arthritis, Perthes, JIA, and potentially a subluxation or dislocation event. So just going to kind of talk about the most common of these. And so transient synovitis is going to be the most common cause of hip pain in a child. We really don't know what the etiology of this is. We think it's some sort of reactive inflammation to a recent viral illness or to a trauma, but we don't actually have a good understanding of what causes this. Typically, patients will present with insidious onset pain, limp, or inability to bear weight. Usually they're afebrile, but they may have a low-grade fever. And when you see them, again, their hip is going to rest kind of in that slight flexion, abduction, and external rotation to help relax the joint capsule. They're usually, especially when they first present, will be reluctant to have you move the hip. If you compare their motion from side to side, internal rotation will usually be limited on that side relative to the other side. But usually they will tolerate some hip motion, unlike a patient with septic arthritis, who's usually very, very resistant to you moving or manipulating the hip at all. And typically what we'll do in the emergency department is give them a Toradol. And so we'll give them a strong anti-inflammatory. And a lot of times with that, their pain will improve and they'll be able to get up and start walking around. And that gives us some really important diagnostic information. When it comes to septic arthritis, again, just kind of getting into sort of the pathophysiology, this can occur a number of ways, either through hematogenous spread, inoculation, or spread from adjacent osteomyelitis, which we can see happen in the hip joint. Typically, this will be either insidious onset or more acute onset hip pain, limp, and inability to bear weight. A lot of times these patients will be febrile and they'll be pretty toxic in appearance. But in practice, I've been surprised at how non-toxic these kids can sometimes appear and how willing they sometimes are to have you manipulate the hip. And so when it comes to differentiating the transient synovitis versus the septic arthritis kids, that can in real practice be sometimes more challenging than it is kind of in the textbook. And then if they have cellulitis or osteomyelitis, they may also have localized swelling, warmth, erythema, and tenderness to palpation in association with kind of their hip pain. So again, one of our big diagnostic dilemmas that we often run into when these kids come into the emergency department is this a transient synovitis that we can just give anti-inflammatories to and send home? Or is this a septic arthritis that may need an urgent surgery? So usually the workup that we start with is going to be inflammatory markers, X-rays, and then a hip ultrasound to look for an effusion. We have this Coker-Caird criteria that we use that can kind of help us distinguish better. Is this more of a transient synovitis picture or a septic arthritis picture? And so you get 1 point for each of these. So inability to bear weight, fever greater than 101.3, an elevated white count, an elevated ESR, and an elevated CRP, with that fever and an elevated CRP sort of being the most a diagnostic for a septic arthritis. When it does seem more like a septic arthritis picture, then typically we're doing a hip ultrasound or an ultrasound guided aspiration and getting an MRI in order to definitively prove that or to rule out any sort of surrounding infection prior to taking that patient to surgery. And then Perthes disease. So this is something that we typically see in kids between ages 4 and 10. This is idiopathic osteonecrosis of the femoral head. Again, etiology isn't completely understood, but we do think it's likely a combination of genetic and environmental factors. This is more common in males, and it tends to be more common in your hyperactive males. Uh, uh, like with these other pathologies, it usually presents with insidious onset limp, with or without hip, thigh, or knee pain. And usually what you'll see on examination, even if they're really not complaining of pain, is that hip abduction and hip internal rotation will be limited relative to the unaffected side. But a lot of times when this first presents, it can look a lot like transient synovitis. And so in any patient that I'm consulted on with transient synovitis, even if they're doing well, they go home, their symptoms resolve. Usually I will try to get them back in another kind of 2 to 3 months to reevaluate them to just make sure that that wasn't the initial sort of presentation of Perthes disease. Since a lot of times these families, once they learn about transient synovitis, anytime their child starts complaining of those symptoms again, they just assume that it's the same thing and not related to something else. When we talk about Perthes, there's this Waldenstrom classification, which talks about sort of the stages of the disease. And again, a lot of times you can see kids who present sort of in different stages. So I think it's just important to be aware of what those are. So we have the initial stage. This is where limp and pain are variable. Often it's mild and intermittent. When we look at x-rays, usually we'll just see a little bit of medial joint space widening because of synovitis and inflammation within the joint. And then you'll start to see increased density of the femoral head. In the fragmentation stage, this is really where those hip symptoms become much more pronounced. And so usually this is when they're presenting, they'll have a lot more pain. The limp will be much more noticeable and more persistent. And then this is where we'll start to see more fragmentation of the femoral head on X-ray. Once we get through the fragmentation stage, then patients enter the reossification stage, where basically the bone starts to or the body starts to lay down bone again, and then we move into the healed stage, where maybe we'll see kind of secondary issues related to kind of their residual deformity. And so the graph on the left is sort of the modification of the Waldenstrom classification that really sort of breaks down these stages more. But I think what's really important is just to kind of see how the x-rays evolve as the condition evolves and what it can look like. Sort of at each stage. And then something that you may see, especially in your adolescent patients who had Perthes when they were a child, is issues related to sort of the residual deformity with Perthes. And so kind of this classic deformity that we can see is patients will have this sort of mushroom head, this really ovoid, large head, a short femoral neck, trochanteric overgrowth, which can lead to extra-articular impingement, and then they may have a fairly significant leg length discrepancy. And so this may be something that didn't bother them when they were younger, but then as they kind of get into their teenage years, this can start to cause more symptoms. And so if you see sort of this X-ray, it's very classic for residual Perthes. And so that brings us to the adolescent who comes in with hip pain. And so again, sort of the common things that will bring the adolescent patient in are going to be apophysitis or tendinitis, snapping hip, hip dysplasia. So this is when someone with residual hip dysplasia, this is usually the age where they start to actually have pain and symptoms secondary to it. Femoral acetabular impingement or FAI, pelvic avulsion fractures, slipped capital femoral epiphysis or SCFE, and then again, hip subluxation or dislocations. And so just starting with apophysitis, and so this is inflammation of one of the pelvic apophyses. The iliac crest is going to be the most common variety of this. And so, when patients come in and you ask them, hey, point with one finger, they'll kind of point right to the iliac crest. Sometimes they'll have pain sort of more over the kind of lateral part of the iliac crest, but sometimes patients will even come in more with posterior kind of iliac crest symptoms, but it's always kind of very focal to that area. Typically, this is an overuse injury from repetitive stress or forceful activity. So we see this a lot in runners and soccer players and dancers, people who are doing a lot of repetitive activities. It is associated with tight muscles. So this is often something that I'll see when a child has gone through a growth spurt, or if they were out of season, they haven't been super active, and then at the start of their sports season, where they go from doing not a whole lot to a whole lot, where they start to have these issues. Often this can be confused for tendinitis, and this really is sort of the pediatric version of tendinitis. It's just that the location of the pathology is a little bit different. And then what's important to know is that this can progress to a pelvic avulsion fracture. And so when we have inflammation of this growth cartilage, it does weaken it, and it may make it more likely for a patient to then develop an avulsion fracture, which can be more serious. And so again, typically presentation is going to be insidious onset pain and swelling. Symptoms are going to be worse with activity. So whenever they activate that muscle, whenever there's contraction of the muscle that inserts on that growth center, it's going to cause pain. If they have iliac crest apophysitis, because the abdominal muscles insert there, they may also complain of pain with coughing or with bearing down. And then usually on exam, they'll have point tenderness kind of right over that apophysis. And so this is really kind of one of those diagnoses where it really is based on kind of physical exam findings, and imaging is really just there to make sure that we're not missing something else, or we're not missing maybe a minimally displaced or an early avulsion fracture. And so pelvic avulsion fractures are more of like the acute injury version of this. Again, typically adolescent athletes during sport. AIS fractures are more common in younger patients. This is where the rectus inserts, and then ASIS and iliac crest fractures are more common in older adolescents. And so this patient here on the right is someone who has an AIS avulsion fracture. And again, sometimes, that appearance on the right, even though it looks a little bit more pronounced, it can be difficult to tell if this is real or not, if we're not getting kind of pelvic x-rays and not getting comparison views. And so you can really kind of see the difference when you look side to side. And so presentation, usually this presents acutely with sudden onset pain and weakness. Patients will often complain of a painful pop when this occurs, and then they'll limp or not be able to put weight on the leg afterwards. And then depending on where the injury is, any sort of passive stretch of that muscle is going to cause pain. And so, again, we have these apophyses all over the pelvis. And so, top left is where you sort of see an iliac crest, a minimally displaced iliac crest avulsion fracture. Again, this can be sort of the normal appearance, but you can really see sort of the difference side to side, which helps you kind of confirm that this is a fracture and not just potentially apophysitis. The X-ray here in the middle is going to be your ASIS avulsion fracture. The one on the far right is going to be of the ischium. And then, I think these injuries often sort of get a reputation of being fairly benign and not having any sort of secondary consequences or sequela. But this is a patient of mine here on the bottom left who had an AIS avulsion fracture. He kept re-injuring it and then basically developed this big exostosis. Which you can kind of see better depicted on the 3D CT on the right, which was causing him a lot of issues secondary to hip impingement. And so sometimes, depending on how these heal, they can really be bad actors. Another thing that can also be helpful when it comes to just, working these up is oftentimes we'll usually just get an AP pelvis X-ray. But if you think of the ASIS and the AIS, when you think about the plane of those growth centers, a lot of times your false profile view is going to be a much better view to sort of see those structures in face. And so if I am concerned about one of those injuries, a lot of times I'll also order bilateral false profile X-rays, again, just for comparison, if I'm concerned about potentially like a minimally displaced pelvic avulsion fracture that I can't really fully appreciate on the pelvis X-ray. All right, and then that brings us to hip dysplasia. Again, in adolescence, that's typically when this is going to start to become symptomatic in terms of causing pain. And so, as we're all aware, this is abnormal development of the acetabulum resulting in femoral head under coverage. This could represent either missed DDH as a baby, but this also may represent abnormal development later on in childhood. A lot of times we don't really know sort of when it developed, but it's usually in adolescence when it becomes symptomatic. And then risk factors for both infantile DDH as well as the adolescent hip dysplasia. There's a lot of overlap in that it's more common in our female patients, and there's usually a genetic component. But again, we ask about breech position, if they were firstborn, and then any kind of underlying ligamentous laxity. On presentation, they'll complain of insidious onset groin or lateral hip pain. They'll often have abductor fatigue and walk with a Trendelenburg gait. Symptoms are going to be worse with prolonged standing or sitting and upright activity. They'll have pain with Fader and Stinchfield. There are some other provocative kind of tests that are described for looking at hip instability, such as anterior apprehension or your prone apprehension relocation test. And so if a hip instability is a component of it, those will also be positive, and you can kind of see those here on the right. These patients will often have increased femoral aneurysm, and they also may have an increased Beighton score. And so I always like to kind of document sort of what their version is and what their Beighton is. FAI, so this is an anatomic abnormality resulting in abnormal contact between the femoral head and acetabulum. As we have our cam impingement, our pincer impingement, and then mixed. Cam impingement is going to be more of a femur-sided problem. So this is going to be due to asphericity of the femoral head and neck. So you can see an aspherical femoral head, decreased femoral head neck offset, or that kind of classic pistol grip deformity. We can also see this in patients who have femoral retroversion. And so when I'm, managing a patient who I think has, symptomatic hip impingement, I like to kind of get a sense of what their femoral version is. This is very common in young active males. When we look at young active males, we can sometimes see this just sort of as an incidental finding, and up to 60 to 70% of the time. We can also see this in patients who have slipped capital femoral epiphysis or Perthes disease, where they develop this cam type impingement because of their residual deformity. And then pincer impingement is going to be more of your acetabular sided problems, so either from acetabular retroversion, coxa profunda, acetabular protrusio. Typically, we see this more in active women, but certain conditions can predispose to protrusio, and so Marfan syndrome is one that's kind of more commonly associated with the protrusio kind of deformity, like you can see here, sort of on the far right. And then again, in presentation, they'll present with deep groin pain. They'll often have mechanical symptoms such as clicking and popping. Usually symptoms are worse with prolonged sitting and deep hip flexion. On examination, they'll have limited hip flexion and internal rotation. And sometimes it can be a little bit difficult to sort of determine when I'm evaluating a patient, is this someone who's having kind of more, maybe they have some borderline hip dysplasia or some hip instability, but they also have some FAI morphology. And so I really look at what their hip range of motion is to kind of help me differentiate that. And so these patients will often have very limited hip flexion and internal rotation. But again, they'll have pain with Fader, with Faber, and with Stinchfield. And then finally, slipped capital femoral epiphysis, or SCFE. So this is going to be separation of the capital femoral epiphysis through the physis. This is the most common hip disorder in adolescents. Typically, this occurs in ages 10 to 15. Risk factors for this are going to be obesity, male sex, endocrine disorders. And so if a really young patient presents with this, someone under the age of 10, or if their weight is under the 50th percentile, then this is really someone that you want to be working up for an underlying endocrine condition. Similarly, if someone comes in and they have an underlying endocrine condition and they're having issues, then I always want to make sure that they're not they're not dealing with a slip. Other risk factors include femoral and acetabular retroversion, or if they had prior radiation therapy. And so this again is really where it's helpful to kind of know what their history is. A lot of times this, especially with very mild slips, if you just get an AP pelvis, it can be easy to sort of miss this. And so this is one where it's really important to get that frog view, because a lot of times that's where we're going to kind of better appreciate this. On presentation, again, patients will either present with acute hip pain, so especially an acute slip or an unstable slip, they'll have sort of this acute onset, severe hip pain, but it can also be insidious in onset. And again, this is a condition where, patients will complain of hip pain, but they also may complain of thigh and of knee pain. And I've had multiple patients who've undergone rounds of physical therapy. I've had patients who've had knee scopes, who've had invasive procedures for their knee when really it was just referred pain for their slip. So it's a very real phenomenon. And so again, I encourage anytime someone comes in with knee pain, especially if they kind of look like your classic kind of skiffy patient, to just make sure that you're also getting pelvic x-rays as well. Especially in the more kind of chronic or insidious onset skiffy patients, they'll usually walk with a slight limp, and the foot will be externally rotated, especially relative to the other side. And so this is where, again, where asymmetry you kind of want to treat as abnormal until proven otherwise. And so when I see a patient come in and they're really walking with that kind of marked external foot progression, I'm always thinking, is there a slip here? If they are not able to bear weight, then that's really a sign of an unstable slip. And so an unstable slip is where we're not able to bear weight even with crutches, and that has a very high association with AVN. So that's something that if you recognize it, you really want to make sure that you act quickly. On exam, they'll have limited flexion and internal rotation, and they'll have this obligatory external rotation with hip flexion. So you go to flex the hip up, and then the hip will kind of want to go out to the side or externally rotate. And you really can't even flex their hip up in neutral. And so we call that Dremen sign. And that's very classic for a slip. And so, whenever I'm, again, seeing a patient who's coming in with thigh pain, with knee pain, I just flex the hip up, and a lot of times, you can kind of get a sense of if there is a slip or not. And then slip severity is kind of based on the Southwick angle. And so maybe a little bit out of the scope of this talk, but when it comes to the management of SCFE, the severity of it does play a role in how we manage it. Regardless of the severity, if someone comes in with a slip and they have an open physis, then that is always someone that I encourage to just be sent to the emergency department and to get it stabilized. But when it comes to the actual surgical management of it, slip severity does play a really important role, especially considering kind of what their residual deformity might be and what long-term issues they may have related to the slip. All right, so I know that that's a lot of information, and again, by no means exhaustive when it comes to looking at the hip in the pediatric patient. But I also want to make sure that there's time for questions and things. So, in conclusion, again, this, seeing pediatric patients with hip problems, there are a lot of challenges, and so it's really important to start kind of narrowing down that differential as you see them, while also making sure that you're not missing anything else that's going on. It's super important to know what normal is to be able to recognize abnormal. And again, sometimes we see things on X-rays, but that's not really what brought them in. And sometimes we don't see things on X-rays that are just because of the fact that this is a developing child, and they're having issues with the structure that doesn't show up on X-rays. So proper diagnosis really does depend on everything. It depends on getting a good history, on doing a really good physical exam. It depends on getting the proper imaging and interpreting it correctly. You really need all of these things in order to come to the correct diagnosis. And again, hip pain does not always mean a hip joint problem. So again, just kind of put sort of this differential up there as a reminder that a lot of things will present with hip pain, and so just kind of don't forget, to think about these things as you're evaluating a patient, because sometimes you can catch very real, very serious pathology by keeping these things in mind. All right.
Thank you so much. That was great, great overview. And I feel like you made a very challenging topic simplified so that we can understand it. I'm sure we have lots more to learn about it, but thank you so much.
Yeah, of course.
If anyone has questions, feel free to unmute yourself or you can put the question in the chat, whatever is easier for you. If no one has any, I have one. When you're looking at pediatric patients with open physes, how often are you getting MRIs or are you using CT scans more if you're trying to determine if it's surgical, non-surgical?
Yeah, I mean that's a great question. With MRI, it really kind of depends on what I am looking for. A lot of times for me, MRIs are still going to be more sort of surgical tests rather than necessarily kind of confirming my diagnosis. Where I tend to use MRI more kind of in younger patients, especially patients with open physes. So with Perthes, we now use a special kind of perfusion MRI protocol to better quantify femoral head involvement, and that can be really helpful, especially in determining whether or not a patient would benefit from a containment procedure or not. We use MRI all the time in patients who come in when we're concerned about an infectious process, or if we're concerned about an underlying tumor. If someone comes in and I'm concerned about a stress fracture, we'll use MRI in those scenarios. I think that trauma is a way where, or is a place where MRI is maybe not utilized enough in our patients with open growth plates. When patients come in following a trauma with a hip issue, especially when you look at like hip dislocations, so much of the acetabulum is cartilage. And so if we're just looking at a CT scan, we can really miss major injuries by only looking at X-ray and only looking at CT scan and not, looking at an MRI. So I also get a lot of MRIs when it comes to patients who come in kind of in a trauma who have an injury around the hip. And then when I'm taking a patient to surgery, a lot of times I will like having an MRI. Even if I feel fairly confident in sort of what the diagnosis is, when it comes to a younger patient, I do think sometimes it is helpful just to make sure that we're not missing something. And so, I remember having one patient who had fairly significant acetabular dysplasia. And so, we get an MRI to look at their labrum, but they actually had an osteoid osteoma in their acetabulum, which we would have completely missed had it not been for the MRI. And so, MRI can sometimes help you, make sure again that you're not missing some of these weirder things that may be lurking there. But a lot of times it is in that setting still a test that I'm getting more for a patient that I'm taking to the operating room.
Thank you.
And I will say, just in terms of advanced imaging, too, something that I didn't really have time to kind of get into for this talk, but it's also sort of a really exciting area when it comes to pediatric hip conditions and hip preservation is dynamic ultrasound evaluations. And so in a lot of our patients, again, it's in clinical practice, being able to distinguish between the patient who's having issues secondary to impingement or secondary to dysplasia and hip instability. These can be really challenging to sort of distinguish sometimes in practice. And so, hip ultrasound has a lot of roles when it comes to diagnosing these conditions, especially the dynamic component of it and combining dynamic hip ultrasound with diagnostic injections. And so it's something that, I'm working on, hopefully building here, but it's a really exciting kind of area within sort of this space. And so if anyone out there is interested in ultrasound or in hip ultrasound, there's a lot of utility for that too.
Thank you. Yeah, that's good to hear too, because I know a lot of us non-operative sports medicine doctors, we use ultrasound a lot. So that's helpful to hear that you're seeing utility of it for your hip exams too.
Oh yeah.
All right. Well, I guess if we don't have any further questions, we can let you go for the evening. But thank you so much again.
All right. Yeah. Thank you so much.